Good evening, class. This is Professor Strev, and I'm doing a voiceover of my recaps and reviews. This is for Unit 10, Care of Patients with Common Mobility, Sensation, and Cognition Problems. Just as I did for Unit 9 and Cardiac, I'm going to go over what the nurse's role is for this. Once again, the book is very specific on a lot of things. Your syllabus talks about the need to understand seizures and epilepsy, Parkinson's, MS, stroke, how to worry about eyes, cataracts, glaucoma, that kind of stuff, and then hearing loss, migraines, things like that. The book has a lot of great information. It's a wonderful resource. The videos that we put out there, the discussion posts, they all help you with this. What we're going to focus on here, though, is what the nurse's job is going to be as it pertains to these type of patients. So just kind of starting out with our patients here, migraines is something that your book talks about, and it seems simple enough. Migraines are headaches, right? We know that migraines cause severe pain, sometimes can be debilitating. It can cause a lot of nausea and vomiting, severe sensitivity to light and sound, and it can be very problematic. People who have migraines a lot of time miss work. They're on multiple medications that really help kind of curtail the pain and get them through the day. It's horrible. If you ever have migraines, it can be debilitating. So what are we going to do about this? Well, you as a nurse, once again, aren't going to do a lot of things here to fix it, but priority teaching is something that we're going to think about. Patients who are taking medications, all right? Those are things that you have to focus on. You need to take your medication as soon as the symptoms start to develop. That is how you're going to achieve your greatest relief in pain. You have to be very proactive. You have to look for those auras that kind of pop up and let you know a migraine attack is on its way. So the sooner you can teach your patients to medicate, the better off they're going to be. Make sure they understand that it is okay to take certain medications together. You can take, NSAIDs or something like that if you need to for other pain, along with your medications to treat migraines, because they kind of work differently in the body. But there are things you have to worry about, like SSRIs. We know you can't take those with anything. So your role in this is going to be patient safety once again, understanding how to help the patient achieve the best outcomes, what to talk to your patient about, safety type issues, and that's where you're going to focus your attention. Seizures, epilepsy, this is a big topic. I think everybody understands what a seizure is, right? It's some kind of disturbance in your brain function, and it can cause convulsions, uncontrolled movements of the body. It can cause sensations to be a little bit weird, loss of consciousness. Patients can have different types of seizures. You could have a tonic-clonic. You could have, which is we call a grand mal seizure, which is the most intense type. There's just a lot of stuff that's kind of going out there. So your job in this is not to fix the seizures or the underlying cause, but to be able to understand what it looks like and how to talk to your patient about recognizing when they might have a seizure. So look for those things like an aura, and help your patient realize that if certain things occur, certain events start to happen, maybe a seizure is in their future. Laying down at that point might be something they should do there. Think about the type of medications they're going to be taking. These patients are going to be on anti-epileptic drugs, and these AED medications, they're very, very helpful, and we know that they are going to do great things for our patients, but they also have some inherent risk. We know that women are more at risk for osteoporosis if they have seizures and they're being treated by AEDs. That's something to talk to your patients about. When a patient starts having a seizure, what do we do safety-wise? We want to make sure that they don't hit anything, so we lay them on a flat surface. We try to pad the bedding. If you're in the ER and you have a seizure, we put bed rolls and padding around the bed so you don't hit your head against the metal frame of the bed. We don't put anything in your mouth. We just try to make sure if you vomit, you turn the head to the side and let the fluid kind of go out. We want to prevent aspiration. That's a big thing. If they have tight clothes on, loosen anything that's restrictive. Make sure that you record the start time so you know how long it lasted. If there are dangerous items around, sharp stuff or heavy, statues or something that could fall on you, that stuff needs to be moved out of the way. So what we're talking about with somebody who having a seizure is the role of the nurse is understanding what it is, teach your patient about medications and things of that nature, and then try to figure out a way to prevent further injury when a patient's actually having a seizure. That's where you need to focus your attention. Parkinson's disease is a slow progressive disorder of the nervous system. We've seen a few people with Parkinson's disease. I know you can think of Michael J. Fox and kind of where he was at back in the day in Back to the Future, and then where he is today. It's very debilitating and a crippling disability in that you lose kind of some muscle tone and things like that. So we know that some of the big features of Parkinson's disease is that stiffness in the muscles, that pill rolling in their fingers, they kind of do this a lot, that slow shuffling gait, the inability to pick their feet up, so that puts them at risk for falls and tripping. So those type of things are things you need to think about with your patient. Make sure they understand that falls are inherently more likely now, and that they shouldn't have throw rugs on the floor. They should have well-lit things. They should have hard-soled shoes, not slippers and things like that. These are where you need to think about patient safety. Because these patients have limited mobility and are more likely to fall, patients who have advanced Parkinson's disease often aren't able to stay at home alone, right? So, we're going to have to think about ways to ensure their safety. It's hard. It's hard to live somewhere. You might need to get some, extra help to come in and really see what's going on, especially in the home, to prevent those kind of falls and things of that nature. Teaching for somebody who has Parkinson's disease is going to be very, very important. You need to think about ADLs, their activities of daily living. It's going to be hard enough to get these done, so they need to make sure they schedule the most of the things that they do in the day should be scheduled around the medication administration, when the medication is at its height and it's working its best. They're going to have difficulty eating enough food and staying high enough nutrition. So they need to make sure when they eat, they don't eat things that are void of nutrients. They need high protein, high calorie diet, things that give you a better return on investment. We want nutritionally dense foods. They need certain exercise to really help them. Things like yoga are going to be important to help with their ability to move better, to loosen their joints. They need to make sure they take their levodopa, carbidopa, at least a half an hour prior to eating. This will help prevent aspirations and things of that nature as well. So while there's a lot to think about with Parkinson's, and there's a lot of patho you can go look into in the etiology and what causes it, you're not going to fix it. Your job at this point is patient safety once again. How are you going to ensure your patient makes it through the day and doesn't, fall or get hurt or have, nutrition less than body requirements? This is where you are getting paid to do your job. Multiple sclerosis is a pretty big concept. I met a guy when I was 19 in the Navy who was my patient, and I was blown away that he was only like 25 and had multiple sclerosis. I didn't know what it was. But multiple sclerosis is that degenerative disease that affects the myelin sheets around the neurons, and it causes severe issues with movement, right? We usually treat it with some kind of immunomodulator infusion. I cannot get that out of my mouth there. Like interferon is the medication that comes to mind when I think about people with multiple sclerosis. But the problem with these type of medications is that they do make you more susceptible to disease and infection. So we have to think about, talking to our patients about monitoring for signs and symptoms of infection. It could be anywhere. It could be you got a nasty little cough, or you got a drippy eye, you got some weird discharge, things you need to talk about. We know that multiple sclerosis manifests as weakness in the muscle spasticity, slurred speech, loss of coordination and vision. It becomes debilitating as well, depending on how bad the symptoms are. So your job is to think about the teaching once again. If you have problems with the eyes, diplopia, you need to think about wearing an eye patch. Think about food. You lost sensation, so you need to make sure you're cognizant of the temperature of water, the foods you're eating, if you're cooking, pot holders. It's all about safety. Wear gloves in the cold. You're trying to avoid exposure to things that can cause severe physical damage as well. Bladder disturbances is something. They might have incontinence and lose their ability to retain, urine. There's just a lot going on with these patients. But what you need to focus on is your job as a nurse, identifying issues, making sure you're teaching your patient how to get through life without further causing damage. That is where you have to really focus your attention once again. Stroke is never going away. We talk about stroke on any program you've ever taken. I know this. This week we've been talking about stroke as well in our discussion post. There are different types of stroke: ischemic, hemorrhagic, and then a TIA, or a transient ischemic attack. Why is it important to know the difference? Well, how you treat them is going to be based on the type of stroke. An ischemic stroke is when you have an occlusion of blood flow to the brain, like a clot, right? If you have a clot, we're going to treat that with some kind of clot buster. Typically, it's going to be TPA, and that TPA is going to bust that clot up for us and cause you to get good blood flow back to your brain. Remember, time is tissue. Hemorrhagic stroke, you have some kind of burst vessel. You don't want to give anything that's going to make you bleed anymore, because that's just going to intensify the issue, because now you're bleeding even more into your brain and you're getting less circulation to the actual brain tissue. So those are some of the difference there. How people present, it just depends on the stroke and the severity of the stroke. I know we talk about that fast, the facial expressions and things like that. It was in our discussion post this week, so you can go back and read those up. But your idea here is who's at risk for a stroke. Know that your diabetic patients, people who are chronically stressed out, the obese, women who are on oral contraceptives, these all increase your risk for stroke. So it's important to be able to recognize. NCLEX and ATI love to ask questions: which of the following patients is the highest risk for stroke? Think about it. A young lady who's on an oral contraceptive, you might not think about that, but that does increase her risk. Understand about the antiplatelet medication used for prevention. There's just a lot going on with these patients. I was going to think of something. A lot of these patients, I was just thinking about kind of what's going on with your patients if they have hypertension and they have increased blood pressure, and how that can affect perfusion of the brain even further. Sometimes you have to give a combination. If you give your TPA medication, it is going to help with that obstructive stroke. So if somebody's having an ischemic stroke, it's going to help bust that clot up for us and restore that blood flow. But then we have to monitor our patients and treat them. So TPA is used to treat the stroke, but then we have to continue doing these neuro assessments at least once a shift after you give it, in order to ensure there's nothing going on. Look for excessive bleeding. Monitor and treat for headaches, for elevated blood pressure, for nausea and vomiting. This TPA can cause that as well. It's going to bust that clot up. So we have to think about these things. Safety is going to be the major concern with these patients. If you have a stroke and you have, if you have a stroke and a loss of blood flow to your brain, we have to think about things like that. So your patient who has a stroke, they're never going to take anything by mouth until they've been cleared by somebody else. They need to do a swallow test before they can eat or drink anything. A swallow test, if you've never done one, is very specific. It starts with a specific sequence. It's very slow, and you don't overdo it. What I love to do when I have somebody who might have a stroke is call somebody from like a speech pathologist or something like that. Have them come out and talk to my patient. Let them assess to make sure that the patient is able to swallow like they should, right? That interdisciplinary team approach where we get the pathologist to come out and talk. These patients are going to have lifelong alterations that are going to need extra help, right? I wish I could tell you more. Go back and look in the book and see what kind of teaching you have. What puts you at risk for developing a stroke? You know, like I said, these are things that come to mind every time I think about a patient with a stroke, right? Think about what leads to a stroke. If somebody has a deep vein thrombosis, we have to be very aware of kind of what's going on. Think about what dislodges the DVT. Think about safety once again. If a patient has a left-sided stroke, think about what part of their hemisphere is gone, where they can see. Where do you place certain items, especially like their a walker or a cane for mobility purposes. Put things on the side of their body that's not affected by the vision changes. And then think about this as well. You could have some muscle issues. So these patients could still be at increased risk for aspiration. Even if they're able to swallow, they might have a decreased gag reflex or cough reflex. They could also perpetuate the issue and make it a little more problematic for our patients who are trying to heal. The ophthalmic ointment, make sure you know how to put it in. Like that's something that your book was very specific about. Understand that you need to wash your hands and the eyes before you start touching them. When you put ointment in, it starts at the corner of the eye and you move outward without touching the tip of the applicator to the lid of the eye. Be very careful what you put in somebody's eyes. You could cause long-term damage if you're putting the wrong substance in somebody's eye. Think about your patients and what to teach them. That's where we're going to focus it on that. So after we think about that, now we're going to get into the actual disease processes that affect the eye. Cataracts. Being able to differentiate between these is important. You know, a cataract is typical, what you see, that opacity of the eyelid, of the lens of the eye. It starts to get a little cloudy looking, people who get cataract, very opaque. And it distorts the image projected by the retina. So it makes it hard for these patients to see. So that automatically makes them at increased risk for falls. So we know this already. What are you going to do about it? Nothing really. The doctor is going to go there and fix that. Your job is to teach the patient how to reduce the risk of cataracts. Wear sunglasses to limit that exposure of ultraviolet light. Wear an eye patch and head protection when playing sports so you don't get any kind of trauma to your eye. Repeat traumas can have that issue. Make sure you talk to your patient about signs and symptoms. You know, what kind of things should you report to your doctor? If you have that sharp eye pain, you should probably let somebody know, right? Flashes of light. What else? Floaters, little floaties in your eye vision could be a sign that something's going on. If you get swelling, the facial swelling, orbital edema, those things can be early signs and symptoms that something's going on with your eyes, and if you can get it treated earlier, you might have better outcomes. So make sure you understand what to teach your patient. Understand what that post-operative nursing care looks like. You're not going to do anything to fix it, but you are going to be with the patient when they come back. And you need to think about orienting them to their environment. Make sure the side rails are up so they don't fall. If they're going to ambulate, you walk with them. Think safety, safety, safety. Think prevention, prevention, prevention. That's what you need to be aware of when you're talking about patients with cataracts. Glaucoma is another one. Glaucoma is when the pressure within your eye starts to get too high, so you get that intraocular hypertensive type issue, so the pressure starts to build. Typically leads to blindness if it's not dealt with. Glaucoma can cause blindness, and it's that gradual loss of visual fields. The central vision is not affected. It's that peripheral vision there. Glaucoma is that painless. It's not like cataracts, but if it's not treated, it can cause blindness. So what do we need to think about? Well, first of all, the risk factors always: hypertension, cardiovascular disease, diabetes. These are always going to affect the small vessels of all of our organs. And think about the vasculature of your eye. it's super small. So of course glaucoma is going to be impacted greatly by anything that messes with your, like I said, cardiovascular or diabetes. Those are the things you really have to think about. Nursing interventions. You're not going to do a lot for glaucoma, but you are going to talk about patient education and medication use. What I do know is when we give these medications, they're to reduce the pressure, right? So we're basically giving like a beta blocker. It's going to decrease the pressure inside the eye. You never want to give, if you miss a dose, talk to your patient about this. If they miss a dose, you're never going to double up on the missed dose and put more drops in your eyes. That's problematic. We need to think about what our job as a nurse is once again. And if you're given I'm just thinking, if you're given medications, what are some of the side effects? Like I said, if we're given a medication that's a beta blocker, understand what beta blockers affect. It's not just your cardiac, but also respiratory. So these people might have narrowing of the airways, and they might present with shortness of breath or dyspnea on exertion. Things like that are where you have to focus. That safety component. Safety is key every single time. Macular degeneration. A lot of folks don't talk about this, but it is something, and it's different from what we just talked about in that glaucoma is more the peripheral vision, whereas macular degeneration typically affects the area of your central vision. Why is that important to understand? Well, you can delineate between the two. So clinical manifestations are ways that we identify. Like I said, the central vision could be a little bit blurred or a distortion. If you notice this, if you have a patient who talks about distorted vision, you need to go to your doctor right away. You and I can't fix that. So we know that the vision declines very fast if you're a smoker compared to a non-smoker. If you start having changes in your color perception, these are all signs that you might need to get checked really quickly before it leads to blindness. So are you going to do anything with this patient? Not really. It's more about the teaching and telling your patient what they need to do in order to prevent further problems. Retinal detachment. This happens for multiple reasons. A hole, a tear, a separation of the retina is what causes it. It just basically deprives blood flow, the blood supply, and you lack the nutrients needed to keep the eye alive. So when you have a retinal detachment, you could definitely go blind if it's not taken care of quickly. They typically repair that by inserting a gas bubble into the eye itself to take some of the pressure away. That's usually what they do. So things that you need to talk about, once again, clinical manifestations. Make sure your patient is understanding that there might be a shadow or a curtain being drawn over their vision. That could be, that is a definite sign of somebody who has a retinal detachment, so make sure they understand that. Flashes of light, those floaters, once again, that could be part of it. So that component, being able to recognize when you have a problem, is part of the teaching that you owe the patient. The other part of the teaching is that discharge teaching. When this patient goes home with that air bubble in their eye, they have to think about avoiding interocular pressure, so no bearing down. If you're constipated, use a stool softener, right? Don't do strenuous activity. Don't bend over. Don't go out and running. Anything that causes strenuous activities, even you name it doesn't matter. House cleaning, going grocery shopping and picking up things that are heavy. You have to make sure your patient is aware that these are the things they have to avoid, and then report back to your doctor if they experience pain or any of the things we talked about with the flashes of light, the floaters, the curtain being drawn over the eye. These are medical emergencies, because if you lose your eyesight and you are blind, it is very life-altering. Hearing and balance disorders, we get into some of this a little bit. We talk about Meniere's disease here quite a bit. So people experience all kinds of hearing problems for different reasons. And when you have hearing issues, it affects your communication. It can also, the inner ear issue can affect your balance as well. So it can be kind of twofold for some of these patients. With Meniere's disease, you have an excess amount of fluid in the ear there, which results in that vertigo, which is dizziness, just constant dizziness you can't kind of get rid of. That tinnitus, that ringing in your ears. It can cause nausea and vomiting as well, almost like seasickness. That's what I think about vertigo. And then you can have some hearing loss associated with this. What are you going to do about it? Well, you personally aren't going to do anything to fix it because it's not your job. I keep saying that over and over because I want you to be aware of what your job as a nurse is, which in this case is going to be a lot of teaching as well and trying to prevent further issues and like falls and stuff of that nature. So we know that treatment includes a low sodium diet, giving diuretics. So you need to think about this with your patient. Talk about what kind of foods to avoid. Think about if a patient's on a diuretic, what that's going to cause. A diuretic is going to cause you to have, a decrease in blood pressure as well. That increases your risk for falls. Having vertigo and this tinnitus puts you at risk for falls as well, right? I'm trying to think what I was going to say here. I think about like don't drive motor vehicles. That might be something you might want to avoid. Avoid high places. Don't climb trees and ladders. Stay off of things that put you at an increased risk of falling. Because of the vertigo, it makes it more problematic. Change lifestyle changes. Avoid caffeine. Right. Make sure you get adequate amounts of daily fluid that is non-caffeinated beverages, non-alcoholic, like water. These are things that you need to talk about your patients with. You're not focusing on what the doctor's doing. You're focusing on what your job is, which is all about that teaching. And the last part we're going to talk about here is hearing loss itself. And we know with hearing loss, lots of different risk factors. Age, always a big thing. Any kind of medical history of ear problems or injury to your ears can definitely cause hearing loss itself. Serving in the military, in a battlefield, working in industries that have unprotected noises. You're not wearing the protective equipment like you're supposed to. Certain medications can be ototoxic as well. So just think about things like that, what puts you at risk. And how do we treat hearing loss? Well, typically we give them a hearing aid. So here comes where you come into play. The hearing aid teaching, once again, a patient's going home with a hearing aid. They don't know how to use it. Your job is to talk about that. So that hearing aid care includes using mild soap and water when you're cleaning it, turning it off and taking the battery out when it's not in use so the acid doesn't leak in there and cause corrosion. Keep them in the case so you don't lose them. I think hearing loss and wearing hearing aids was a novel idea back in the day, but now every one of us have ear pods or something we put in our ear, so we're way more familiar with what it means to take care of these. But don't overlook the little stuff. I know it sounds like we didn't go over anything, and we didn't talk a lot about disease process or anything else. That is because we're not going to test you over that. We are going to test you over what your job as a nurse is. Your job as a nurse is to ensure patient safety, that teaching, the things that you have some kind of control over. Think assessment data and nursing interventions. And that is how you pass these classes.